morning, and sorry for the brief delay. We were supposed to be with you live at 4 Eastern time, but we've run into some technical difficulties, but thankfully we've overcome them. My name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association, and today I am joined by Dr. Iacopo Olivotto from Florence, Italy, who is going to be presenting to us some new data that was just announced at the ESC conference this past weekend on the Mavacamten Explorer trial. I do want to let you know that at the end of this talk, we will take some questions, and you will be able to ask the Dr. Olivotto, one of the principal investigators of the study, questions about the study design or about the study results or where we are in the process. But understand that anything futuristic or any hypothesis that he may have that is not presented is not appropriate to be discussed, because this is not an FDA-approved drug at this point. This is a clinical trial. So without any further ado, because it's been taking us a while to get to this point, welcome to Facebook's HCMA page on Facebook, Dr. Olivotto.
Thank you, Lisa. Thank you for having me, and it's always exciting to talk to the friends at HCMA. Actually, I think this is always the most challenging audience that I can imagine, but also the most rewarding. So I'm really happy to be with you. I've just present the slides, which were largely part of my my talk at the European Society of Cardiology, which went live in a totally virtual manner this year. And I was telling Lisa, we had 100,000 registrants from all over the world. So I don't think they were all online at the time, but this definitely is a trial that got top attention. It was presented at the very initial session after the inauguration. So really under the spotlight, and under many, by many experts, this has been considered like one of the, if not the most original paper presented and trial presented in the Congress. The reason being that this is a disease that is still orphan of specifically designed treatments. And this is sort of really a first in class. So these are my
technical note. I am going to minimize my screen, and I'm not going to be able to be heard. So I'm going to leave you in the capable hands of Dr. Olivotto, and I will jump in after his presentation so that I can make the slides a little bit bigger. I'll be back. Take good care of my crowd.
Thank you, Lisa. So these are my disclosures, and the study was funded by Myocardia, and I was the principal investigator and part of the steering committee. So I will not talk about HCM, because that I think is not necessary with the kind of audience we have today. However, I will briefly say that many genetic mutations that cause hypertrophic cardiomyopathy are a sort of a natural doping. The way I explain this to patients is that their hearts are naturally doped in the way that sports people usually would try to by improving artificially, but in this case, it's a natural thing occurring, of course, increasing the performance of the heart by increasing the interactions between actin and myosin, which are the main components of the heart machinery, the actual contractile protein. So this is a disease of too much of a good thing. There is too much contraction, which in turn leads to hypertrophy, diastolic dysfunction, and very often impaired energetics and obstruction. Obstruction is a consequence of excessive contractility. What the drug does, what Mavacamten does, and what other drugs in the pipeline will do is try to revert that, to counter that by reducing this hypercontractility, reducing the number of myosin heads engaged with actin, and therefore restore like a normal condition in the heart. And the first thing that we can probably measure, because of course there are effects of the drug that we will only be able to measure after years or maybe decades, that in terms of, for example, impacting on the long-term outcome of patients, we still cannot have those data. So what we could do when we designed the trial was to assess something easier, something more measurable. And the first and most immediate thing was gradients and obstruction, because Obstruction is easy to measure. It's easy to see variations. We do this all the time with drugs and surgery. So we enrolled in the study 251 patients with hypertrophic obstructive HCM. Patients had to have at least 50 millimeter of mercury gradient, either at rest, Valsalva, or with exercise. And they were randomized double-blind, so nobody knew what they were taking, neither the patients nor the physicians, with placebo. So about half were on Mavacamten, which was titrated during the treatment period, and half were on placebo. Treatment period was 30 weeks, at the end of which there was a final evaluation. Evaluations were based on a very huge number of assessments, but particularly echo, exercise, echocardiography, as well as cardiopulmonary testing. Patients then enter the washout and are now still going into a long-term extension trial, which will give us more safety information. If you look at the type of patient, the demographics of the patient, so what these patients, do these patients look like? Well, they're really very much similar to the patients we see in clinical practice. And this is important because sometimes trials enroll patients that are very different from the patients you see in clinical practice because of all the inclusion and exclusion criteria. In this case, mean age was 58 years for both the Mavacamten and placebo arm. There was slightly more female in the Mavacamten arm, but otherwise the two groups were very well matched for a number of clinical features. If you look at the echo parameters, you see that they all had an ejection fraction that was high. So the heart was indeed hypercontractile, which is usually the case in HCM, and the gradients were high. So an average gradient of 50 millimeter of mercury at rest, which would be considered sort of an ideal threshold for surgical intervention. Although these were largely class 2 patients, so not immediate candidates for surgery, and post-exercise gradient of as high as 84 and 86, so really severely obstructive patients. So what are the results? First of all, the endpoint, the primary endpoint of the study, which was designed very carefully in accord with the FDA, because this is a phase 3 study. So we want to get the drug registered and out there for patients. And we had to design a study that would be agreeable to the FDA in this respect. And they wanted something objective as well as a measure of well-being of the patient. So the primary endpoint was a combination of either an improved performance, a mildly improved performance on cardiopulmonary testing, but with symptomatic improvement of at least one functional class and YHA class, or a greater improvement in peak VO2, so in cardiopulmonary testing performance with no worsening of functional class. Well, and you could have either and be a responder. In fact, the primary endpoint here was met by 37% of patients in the treatment arm, as opposed to only 17% in the placebo arm. So there was a 20% absolute margin of benefit for the drug compared to placebo, and the p-value here, so the degree of statistical significance was very, very high. You see all those zeros in the p 0.0005. Interestingly, one patient every 4 achieved both the improvements, so both the high threshold for cardiopulmonary improvement as well as the functional class improvement. So one patient in 4 had an excellent result in this respect. If we look at the secondary endpoints, which in some way were even more important clinically, you see that the main drop, there are many numbers here, but just follow the column under Mavacamten here. You can see that the mean change in gradient from baseline to end of treatment was almost 50 millimeter of mercury. So the exercise-associated gradients dropped almost 50 millimeter of mercury, which is a really impressive result, as opposed to only 10 in the placebo arm. You can see that there was a higher improvement in cardiopulmonary testing result capacity, and YHA class improvement in 65%. So 65% of patients improved at least one functional class, as opposed to only 30% in placebo. And the last two lines here, the CCQ and the HCMSQ SOB, were two scores the first one was a general cardiomyopathy score, which definitely improved here by several points. And the second is even more important. The second is a questionnaire, is a tool that was developed specifically for patients with HCM and specifically validated for this trial. And you can see here that in this case, a negative minus is a good point, is a good thing. Sorry about that. So you can see that it's a negative result, which in fact means improvement in patients, very significant compared to placebo. So all the primary and secondary endpoints were met with very high degree of statistical significance in the study. If we want to visualize this a bit more sort of graphically, because numbers are a little boring after a while, this is a table, it's a figure that is actually part of the paper that was published in the Lancet Saturday. And you can see the numbers here. You can see the patients on placebo are in orange and the patients in Mavacamten are in blue. And if you look at the top left panel, this is what happens with exercise echo. You see that the starting gradient is very high, we know that. The placebo stays relatively stable, whereas patients with Mavacamten drop well below the threshold of 50 millimeters of mercury, which would be considered a threshold for surgical or percutaneous intervention with an average of 38 millimeters. If you look at of mercury, if you look at the two bottom panels, what you see is at different time points from the beginning of treatment, the gradient at rest and with Valsalva drop very significantly, rapidly, and in a sustained manner, so that at the end of the treatment period, you can see that most patients will have actually dropped under the threshold of 30 millimeters of mercury, which means these patients are not obstructive anymore. They have an ideal results in terms of hemodynamic improvement of their condition. And how did this happen? This happened because the drug reduced contractility and reduced the systolic anterior motion of the valve, and therefore eliminated the gradient. So how much a reduction in contractility was required to do this? Was this a dangerous effect? Did we have to lower heart function too much to do this? No. This was the nice part of this. If you look at the top right panel, what this shows is the drop in systolic function, in contractility of the heart that was necessary to produce the results in the gradient. And you can see that there was only a 4% drop in functional in the left ventricular ejection fraction. So there was a very small drop in function of the heart, which was very safe and well below the safety sort of threshold of 50%. So I would say this is a nice scenario of a maximum effect with minimum decline in heart function. So the next question was, well, did the drug work across the board? Were there patients who benefited more than others? Younger, older, males or females, patients who had more or less symptoms, patients on beta blockers or not on beta blockers. And these are all pre-specified subsets. So we had to specify what subset we were looking at before doing the study. That was also required from the regulatory agents. And it's quite reassuring to see that the benefit in terms of the gradient was similar in all subsets. So the way you read this, the figure is you look at the vertical solid line. That is the line for a neutral effect. So if you are across that line, that means the effect is not significant. Anything that is on the left means benefit provided by Mavacamten, and you can see that the lines here are all to the left, and sometimes very much to the left, meaning that the gradients here, in this case it's gradient we're looking at, are reduced very significantly across all the population. A couple of additional points. These were exploratory endpoints. I just want you to look at the last line here at the bottom. Complete response to the drug. How was this defined? This was defined as an ideal optimal response. So total abolition of symptoms, class 1. So no symptoms recorded, and all gradients, including exercise gradients, below 30. So this would be considered the equivalent of the perfect response to any procedure. And this was achieved by 27%. So you needed to treat less than 4 patients to obtain 1 perfect response, as opposed to virtually 0.8% in the placebo arm. So again, I think this is quite convincing in the sense of efficacy. I don't think we could have dreamed of a better results in terms of efficacy for a study like this. And then the last big question comes up. Oh, sorry, this is biomarkers. So we also looked at molecules that are circulating in the bloodstream that are either expression of the strain of the heart. So on the left, proBNP is a measure of how much the heart is under strain. The higher the measure, the more the heart is under strain and possibly decompensated. And you can see that this fell very nicely, meaning that the heart strain was reduced very soon and very consistently. On the right, you have troponin, which is a measure of heart damage, showing again that the blue line, the treatment arm, reduced heart damage, spontaneous heart damage caused by the disease. This is important because it implies potentially, we have to show this, but potentially long-term benefit of the drug. So the final question is, well, the drug works. I think there's little question that the drug works. Is the drug safe? Can I give it to my patients? Did we see any sort of adverse event or side effect that would limit my use in our population? And again, fortunately, we did not see this. So there were some adverse events, some of them considered serious, like atrial fibrillation or heart failure, but the percentage, the rate, was exactly the same in the Mavacamten arm or in placebo. If anything, there were a little more problems in the placebo arm, which is also conceivable because they had gradients, whereas the Mavacamten arm did not have gradients. So, for example, atrial fibrillation slightly more prevalent in the placebo arm. But overall, the safety profile of the drug was comparable to placebo, and even patients who had to transiently discontinue the drug because of a drop in heart function resumed their function after washout. Only 7 patients had to do this, and then were able to complete the study successfully. Only 3 patients had to drop from the study. 2 were on Mavacamten due to minor problems not related to the drug, and there was only 1 on placebo. And unfortunately, this 1 patient was the sudden death, the only sudden death that we saw in the trial. There was only 1 patient with sudden death, which is unfortunately still in the range of what would be expected out because of the numbers and the duration of the study. And this occurred in a patient on placebo. So no patient had to withdraw due to a drop in systolic function or heart failure. So these were my conclusion at the European Society of Cardiology meeting. We can sum it up by saying that this is really the first time that a drug has been specifically developed and successfully tested in a population with hypertrophic cardiomyopathy. It really is a landmark study in this. And let me say this because I have been through a lot of failures before that. I've been through a lot of hopes and failures. So it's really an incredible feeling to be able to come up and say the drug works, the drug is safe, and let's hope this comes to the patients, and to talk to patients that I have enrolled, so where I have directly witnessed the efficacy of the drug. It has really been extremely rewarding. Most patients did extremely well. Others did well, although not as well, but still quite well. Nobody did badly on the drug. And overall, I think that this is really a game changer, not only because of the drug per se, but because it does show that if you do your homework, if you know the disease properly, if you know the mechanism, and if you develop drugs based on your knowledge, this can really be a success story. And I here would like to acknowledge the fact that I'm just the last here on in this huge process leading from basic science to animal studies, volunteer studies, phase 2, phase 3. So it really is a huge team effort that has brought us here. My co-investigators have done an incredible job. The core labs, the study coordinators, the whole myocardial team have been incredible. And as I said at the end of my talk in the meeting, I think we really are indebted to patients and their families for their support. And we really did our best to deserve their trust, and hopefully they will all benefit from this, let me say this historical trial. Thank you. I'm happy to take any question.
I'm going to readjust the screen here a little bit and get into a nicer layout. Okay, so really exciting data. And I have to say, you know, a huge thank you to everybody involved. You immediately think of the clinicians and the study sponsor, in this case, Myocardia, and of course we thank them. But behind the scenes, the HCMA was working directly with our patient community to encourage people to participate in clinical trials. Without participants in clinical trials, we never know what this concept truly proves out to be. And we were able to partner industry, clinicians, researchers, core labs, and the HCMA and the patients, and we were able to get this study populated in, I think, a quarter of the time as we did with the Gilead study back in those. That was a much smaller number. So kudos to the entire community for everybody showing what teamwork can actually accomplish. I will stop my rah-rah session now and I'll get into some data, because I'm really confused and in a positive way as to mechanism of action. So when I first learned about Mavacamten and what we were hoping to accomplish with it, I thought the benefits would be derived because of a change in ejection fraction. It would help the heart relax more. But it really seems like it's more a mechanism of strain, and that we've improved the strain and that we've relieved strain and thereby relieved obstruction. What do you think is the mechanism for this drop in obstruction?
So I think, well, first of all, a 4% average drop in ejection fraction is small, but it's not negligible. And you can see this acutely, for example, with disopyramide. You can get similar sort of results. And we know with disopyramide, for example, many patients have benefit even with smaller drops in gradient and smaller drops in ejection fraction. But of course, this drug does more. And I know disopyramide has problems, but I mean, you do see responses occasionally. And, you know, sometimes they do, particularly at the beginning of their treatment. But this drug probably does more. So, for example, what we saw was that the end diastolic volumes of the heart, so the heart dimensions, were greater at the end of the study. So there may be some direct effect on the relaxation side that makes the heart slightly bigger, and that helps a lot because, of course, that means that the geometry of the heart becomes more normal, and the valve has less of a chance of getting into a SAM. So we are now looking at the echo and MRI data, and that looks extremely promising. I think we still have to understand the real mechanism behind this, and it's not just contractility. I'm sure about that. So I think you're right that we have to keep learning. Don't forget that when surgeons started doing the myectomy, and they didn't know why it worked, right? So Barry and other people have told this story more than once. So it does work. It has a very sound rationale, and maybe we still have to do some work and understand why at the molecular level, and also why it may work in non-obstructive patients as well. That's something we really need to understand.
So I've offered our viewers to ask questions, and there is a very long line of them. So instead of me digging into the nitty-gritty of the data, I'm going to address their questions, which might answer some of my questions, which you and I can talk offline about as well. So first question was, would this help if you've already had a myectomy? So you just mentioned a non-obstructed population, and that was the Maverick study, which is a partner study to this. Do you want to just talk about that for a moment?
Yeah, so first of all, if you had a myectomy that was not successful, or an alcohol ablation that was not successful, the drug works because about 12% of the patients enrolled in the Mavacamten arm had a previous procedure that was not successful, and they responded well. So it does definitely work. If you had a myectomy and it was a good myectomy, successful myectomy, then we don't really know. I mean, the Maverick study was performed in non-obstructive patients, but it was a pilot study, smaller study, and what it did show is a very nice fall in the biomarkers, so in the troponin and proBNP. That provides hope of long-term effects. But of course, an effect in non-obstructive patients is much more difficult to demonstrate because the symptoms are, the cause of symptoms is much more varied, and the response to any drug is much more variable as well.
So that's a definite maybe. It might, but we don't know yet. Okay. Now we saw that one patient in this group, or two patients actually, developed atrial fibrillation while on the drug, but considering the history of HCM and that 20% plus will develop atrial fibrillation, was that really associated with the drug? Is there possibly any benefits to atrial rhythm burden in this population? Will it have any effect?
So, interesting question. First of all, the rates of atrial fibrillation are largely what you would expect in a subset of patients with obstruction and large atrium, like most of these patients had. It's not a surprise. If anything, there were a little bit more patients with atrial fibrillation in the placebo arm. So definitely it's not, and also the ventricular arrhythmias were exactly the same in the two groups. So there was no evidence of any sort of enhanced arrhythmic risk in patient on Mavacamten. If anything, the other way. Also, we are looking now at atrial size. These data will be presented at the AHA. I'm just allowed to say that there is positive remodeling in patients on Mavacamten, so smaller atria at the end of the day, at the end of treatment compared to placebo, and the reduction in atrial dimension usually is associated with a reduction in risk of atrial fibrillation along the way. So I would expect in larger numbers to see a benefit, not a worsening of atrial fibrillation in patients on Mavacamten.
Do you think there, based on the study results that we've seen so far, is there a role for Mavacamten with apical presentation of HCM, or do we know yet?
So unless there's some obstruction, like mid-ventricular obstruction, and that was not really captured in Explorer, unfortunately. So we have, but unless there is a clear case for mid-ventricular obstruction, where I think it's a very promising option that we have to test, we still have little data to say that it does help. Of course, the aim is to use it to use it and to show benefit across the whole spectrum of disease, except the very advanced end-stage disease. But this is early to say.
So we have the opportunity to still look at things like mid-cavity obstruction and cavity obliteration and all of these other manifestations of HCM. We're not going there yet. We're looking at obstructive HCM here, and that's what these results are here to talk to us about. So, Brian, we already answered that earlier. Gwen asked, how does the drug perform in those who have been diagnosed for many decades? So the people that you had in this study, do we know their time of diagnosis to enrollment in the study? Do we have any data on that?
That's a very good point. I don't have it right off the bat, but I can definitely find it out. In my case, for example, in Florence patients, several of them had been diagnosed many years ago and had been surviving on the beta blockers and disopyramide, doing okay, but not very well. Some of them were not symptomatic enough to go for surgery or were afraid to go for surgery. And I would say there's no limitation there. Duration of disease is not a contraindication or does not highlight patients less prone to respond unless, if they are obstructive, because to be obstructive, you need to have a hypercontractile ventricle. So that's irrespective of the duration of disease. Can I say hi to Marion? I see her name pop up.
Hi to Marion.
Hi, Marion.
Marion just like beamed because you just said that. I can't see her, but I know it. Okay. Frida is asking a really good, I'm sorry, not Frida, Fida is asking a really good question. There was a study published in JACC in June of 2020 showing the med also working in non-obstructives. I'm going to dive in a little bit more here. So in a population, in an individual with a lot of ventricular fibrillation burden, do you think that it is going to be wise to try the drug early in that population, or do we still need to learn more about mechanism before we try it in somebody who has a known history of a lot of ventricular arrhythmia?
No, I think that, provided it's very clear that this is not an antiarrhythmic drug, so that this only takes into account the mechanical problems created by HCM and obstruction. I think there is no contraindication, or there is no preferential issue. I mean, it's pretty much like you would consider surgery or a myectomy or an alcohol ablation. The presence of ventricular arrhythmias should be considered like in a sort of an independent manner. We don't really know that myectomy lowers your risk of ventricular arrhythmias. We do hope so, and there is some sort of retrospective data that suggests that if you lower the gradient, you have less prevalence of sudden death. But in this case, this is definitely not an antiarrhythmic, so you would have to be treating the two things, obstruction and arrhythmias, in a sort of parallel. But it's not a contraindication at all.
I forgot about this. I haven't been using this software in a while. I forgot that I can actually bring their comments right up online.
Oh, that's nice.
That toy. So Angie, you want to know about the use of this drug in pediatric population? Iacopo, you want to talk about where we are with
Sure. Absolutely. This is absolutely crucial for us. Well, first of all, the principle behind the development of the drug is that if given early enough, this drug may revert or at least prevent the disease, or at least some of the manifestation of the disease. So obviously targeting very young patients is the ultimate goal for the people who develop the drug and for us clinicians. Of course, on the other hand, children and adolescents are also the population you would be more reluctant to try new drugs in before you have safety data. So it's sort of mixed feelings. I think it may be very promising in very young individuals, particularly to block progression of disease, block fibrosis. I can tell you that in order to get registration in the European Union, the EMA, which is the European FDA, will definitely require some pediatric data, which usually is a pilot study on small numbers, and we will definitely have to do this, and we'll do this. There are situations like, for example, little children with Noonan syndrome, or who are born with very severe obstruction. They, cannot be operated on because we know that the obstruction tends to recur. They're at high risk because they're syndromic. They have chest infections. So to be able to use this even for compassionate use in such high-risk fragile individuals, for example, would be extremely interesting and important. I think we will soon obtain some data in pediatric patients. There will never be a large amount of patients, of data, because kids are fortunately rare. There are very few pediatric patients, but they're so important to us. So we hope to get data soon.
Yeah, and in the U.S. FDA, they have an encouragement towards looking at pediatric utilization, but we have to prove safety and efficacy in adults before you try to bring in the kids. So it will come later. Betty, I don't necessarily think I agree with your question here. Looks like it was not as effective in those over 65 years old. We just looked at the average ages of patients. You didn't segregate them by response by age, did you, or did I miss something?
No, I think she refers to the forest plot, which is the, it's actually, hang on, let me see if I can show you the
Yeah, we can bring it
figure.
back up on the screen if you want.
Yes, let me do this, because I think she's referring to this figure here. Can you see it?
I can pop it back up in the screen in just 1 second. And there it is, and it's little. And let's see if I can make it a little bit bigger. No, that's as far as I could get it. And it's really tiny. Let me try one more.
Okay, but what the figure shows, if you look at the first subset, is the subset divided by age. And
okay.
if anything, the over 65 do actually quite well, but the three subsets are substantially overlapping. So there's no real difference between the three. So they all responded equally well.
So it's really statistically the same. And I will dive into, I'll go back to this one. I'm going to go into nitty-gritty detail. Not everybody that's watching here is familiar with p-values and what they mean. You want to explain that a little bit to our patient population?
Yes, so the p-value is, because we are looking at the subset, ideally we should do our trials on the whole, world population, because that's the only way to have the truth. Otherwise, if you do a trial, you have a subset, you have a small number of individuals who are taken as representative of the whole, and there are, of course, margins of error. So the p-value tells you, if you repeat the trial over and over again, how many chances you have of getting the same result. And in this case, so if you have a p of 0.001, means you can repeat the study 1,000 times and you will get the same result in all except one case. In this case, it was like almost 10,000. So it was really, it's like several zeros. So it was like 10, you can do the study 10,000 times again and you would get the same result in all except 5. So it means it really is very robust, and it's not just a chance that we found this result. It's really very robust.
I'm going to read Sarah's question live with everybody. Wow, so hopeful after so many years of having the only drugs available have side effects that really don't treat the disease. Any idea of the cases?
Yeah, to have the drug available. Yeah.
Okay. So when does it look like we could have availability?
So now the drug will be the case will be presented to the FDA, and then in Europe I would expect it will take about a year before it's actually out there. I'm not sure whether this can be made any quicker. I'm sure that the FDA is interested. FDA granted the breakthrough therapy designation, which means this may be made a little faster. The process can be expedited a little bit because of the importance of bringing a drug to an orphan disease. But it roughly, I think, will take about a year before it's out there.
So one thing I will encourage everybody who's watching to do is to stay very close in touch with the HCMA. Make sure you like this page. Make sure you're following what we're doing on our website. As soon as any information comes out, we're going to try to get it to you in as quick a manner as possible. Leah says, sounds very exciting. What about those with low EFs where there's no drug given and systolic function reduced? This is not for systolic dysfunction, really. You want to talk about that?
Yes, I mean, I definitely, that is not the kind of patient you would think about for Mavacamten, because again, it is a drug that lowers contractility. In those patients, unfortunately, it's just a different disease. I mean, they have moved from an initial disease to, I sort of usually explain this to the patient with Napoleon going to Russia. Napoleon went to Russia with an overambitious plan, a huge army, and he expended too much of his energies, and then the winter set in and he had to sort of withdraw, and because it was just too cold, didn't have food for the troops. So if you're if you're retreating from Russia, you're not using a negative inotrope. You have to use something that will actually help the heart contract better. So there were other good news from the ESC. For example, there's this anti-diabetic drug that seems to do very, very well for patients with systolic dysfunction, on top of the Entresto that was recently released. So the armamentarium for patients in end stage is getting richer by the day with the standard heart failure treatments. But in those subsets, you would not be happy using Mavacamten, unfortunately.
Okay. So Reinhardt, you're asking if you have non-obstructed but a low gradient. So you've got a gradient of under 30. Is there a use for Mavacamten in that group?
Yeah, I mean, for example, some of these patients, a minority of patients in this study, did not have a high resting gradient, but they had a high exercise-induced gradient. I don't know how many of you are being tested. For example, what we always do is exercise echocardiography. And it's a little bit different from what they do in the States with treadmill, because we echo patients during every single stage of exercise plus recovery. But the treadmill is also good, and it's also fine. If you have a low gradient at rest, you're likely to have a higher gradient on exercise or during recovery. In this case, you would qualify for Mavacamten if you have symptoms associated with it.
And you gave a call out and she asked a question. Congratulations, fewer interventions. She's done some reading, as you know, Marion always does her reading, that Mavacamten can improve diastolic dysfunction, and thereby could it be used by everybody with HCM who has some degree of diastolic dysfunction?
This is definitely the hope. The big challenge here will be showing it in the trial, because the thing is, we've been through this with other compounds. HCM is such a funny disease. So I apologize for the word funny. I just, I don't mean to say it's, but it is so, it has a degree of madness in the way it develops, in the way that you may end up having the perfect drug, the very perfect drug, and not be able to show that it's perfect. So we have, consistently being obsessed by this danger, because if you want to get the drug to the market, you have to show it works according to the rules of the FDA, which are reasonable rules. They want to know and they want to see an effect. And this requires to show either a benefit in survival or heart endpoints, or a benefit in function in terms of exercise testing, performance, and whatnot. And we know that, well, fortunately, heart events are rare in HCM. If you want to show a mortality benefit, you would have to enroll thousands of patients for years, and this is not feasible. If you want to show an exercise testing benefit, for example, the response is really very variable. You have patients with severe symptoms who may perform well on an exercise on a bike, and then eat a pizza and be unable to walk the stairs. And how do you show this in a trial? So this is really our challenge now, because I do think there's a definite hope for Mavacamten in all patients with HCM, provided their function is good. But will we be able to show it in a trial? So this is the next challenge. I'm sure we'll do it, but it will take some time.
So I'm going to ask a couple of follow-up questions. In terms of this study, were the patients on Mavacamten and beta blockers and calcium channel blockers? And do we think that when we're able to use Mavacamten, is it going to be in partnership with other drugs, or is it going to be a standalone?
This is a major question. So first of all, yes, the majority of the patients, over 90% of patients, were actually 95, were either on beta blockers, the vast majority, or on verapamil with diltiazem. In fact, patients on beta blockers showed less of a response in the primary endpoint, because the beta blocker blunts your heart rate response, and so in a way it sort of gives you a worse performance on the treadmill or the bike. Even though the gradients went down equally well, patients with beta blockers showed less of a response in the primary endpoint. Again, this just to show how complex it is sometimes to show a benefit of the drug. These patients benefited as much as the others, but their CPAT response was just not as good. So in fact, in the long-term extension trial, we are now an amendment that allows patients to come off the beta blocker, off the verapamil or the diltiazem, if the clinicians are confident with that. So if they don't have ventricular ectopies or other issues coming up. And there are a lot of suggestions that showing that probably in many patients, Mavacamten may do actually better as a monotherapy rather than in combination. So that's very interesting, and we are definitely looking into this.
So Fabian has a question. From your point of view, do you believe it's a good idea to take Mavacamten if somebody is asymptomatic, but they have obstruction and a larger atria? Is being symptomatic the reason you take Mavacamten, or is it to reduce gradient so that you don't become symptomatic?
Another
I
excellent
have questions, don't I?
These are excellent questions. These are actually much better questions than I get from my colleagues. So, so this is yeah. So, if I were to, my personal opinion, yes, I think one of the great potential advantages of Mavacamten is to treat obstruction from the very beginning. We recently published a paper based on our Florence experience that if you have somebody on a gradient with on obstruction, even though symptoms may be mild or absent, and you wait more than 5 years to operate, the benefits will be less and the risks will be more. So what Mavacamten really for the first time hopefully will allow clinicians to do is to treat obstruction early and systematically, even in patients who would never go to a surgeon in the first place, because the symptoms are not severe enough, but they still have atrial remodeling, will go into AFib, and will have problems. So don't forget also that if the cost of the drug will not be excessive, and this is really something we are eager to understand, because I work in a National Health Service, for example, environment, and this may be a major limitation for patient to access the drug, and we are seeing this with amyloidosis, for example. But if the drug is affordable, don't forget that this is a incredible guarantee to patients. There are entire countries in Europe and elsewhere that don't really have surgical expertise or interventional expertise. There are patients who come to me from I will not say which countries, but they come from me from even relatively wealthy countries saying, I have been around and nobody has done more than 3 myectomies or more than 2 alcohol ablation. I don't want to have a procedure there. Think about the possibility of making this equal for everybody. I still think there will be patients going to surgeons and going to have alcohol ablation. I don't think they will run out of business, but this will definitely allow a first shot to patients worldwide, irrespective of the local expertise. And I think that's a major step forward.
I'm going to get to a couple more of their questions, but I have to give some of my observations as well. We know that the mechanism for obstruction isn't the same in everybody. So I have to wonder if the mitral valve is really guiding the obstruction, that leaflet is flailed or it's doubling back or it's making really significant contact. Is Mavacamten going to stop that problem? I'm not seeing the data that says that it will. What are your thoughts on mitral valve driven obstruction?
Yes, I totally agree with you, and that's a major point. However, the nice thing about MAVA is that you can give it a try. It's totally reversible. So we do this with DISO, for example. We use DISO as a bridge to surgery very often, just to make patients understand how much better they could be, and that gets them very highly motivated. So I think even when you think it's not going to work, you may give it a shot, see whether it works. If it doesn't, you wash out, and then you are actually even more motivated to go for surgery at that point.
So Mark here is asking about being on disopyramide at 500 milligrams a day. Is this a good patient that you would have to wash out of diso and then start on Mavacamten potentially in the future if they wanted to see if Mava worked for them more than diso did, or they don't have to deal with the side effects of diso? And my add-on question, because I know you're smart and you can handle all this at once, were there any side effects noted or complained about by patients who were in the study?
Okay, so yeah, so I cannot answer the question now, but we will answer the question soon, because there is an ongoing study in US only, which is called Valor-HCM, which is actually taking place in a couple of very important international surgical institutions that will assess whether Mavacamten can postpone or reduce the need for surgery, and that will allow the administration of Mavacamten to patients on disopyramide. So that will tell us more about the safety here. It's an important point because Mava works well by itself, but if you have a patient with, for example, paroxysmal AFib, I find diso extremely useful to control AFib as well as mildly controlled obstruction. So the combination of the two would be ideal if you have AFib, for example. If you don't have AFib, you can go for Mava alone. With regard to side effects, well, Honestly, it's hard to say because the side effects that we have seen were the same that were seen in the placebo arm. So there was no clear signal of one side effect that was typical to Mavacamten, and patient reported the same side effect also in the placebo arm. The only thing that was unique to Mavacamten, and I have witnessed this in one patient, was transient reduction in systolic function. I had one patient who dropped. That was actually, he was in the placebo arm, completed the study, then went to the long-term extension. So he went to the open label and got the drug, and he felt absolutely great and much better, improved 100%. However, at one stage, his ejection fraction dropped below 50%, down to 40, and he at that point felt fatigued. So we had to wash out and 8 weeks, and then put him back on a lower dose, and now he's doing fine. So this is the only thing that, of course, there will be patients who respond more than others, and if you respond too much, titration will be a very important point here. And there are, again, Valor HCM study will also help us understand more how to titrate the drug without making, having blood samples taking as we did in Explorer.
So for anybody interested in more information on Valor, I'll be posting some stuff in the next couple of weeks. I actually have a call with the Valor team next week to kind of go over recruitment strategy and see if we might be able to assist in that endeavor as well, or at least make the information available and all the study sites available in an easier way for our population. So stay tuned on that. Okay, so there's a couple more comments, and then it's really late in Italy, everybody. So can we get a, thank you to Dr. Olivotto for staying up so late to hang with us. I know you all appreciate him as much as I do. So here's a happy one. Christine said, I never thought she'd see this day for her HCM warriors, and yay, we're doing it. And it really has been amazing, and there's some other trials coming up as well from another manufacturer, but it's to see this breakthrough, to see this aha moment that we're looking at a new mechanism. I mean, we're not stealing a drug from somebody else. We're actually getting our own. And for other diseases, they may say that's silly. We have 14 different drugs. We have 0. We're stealing from everybody else.
And also, Lisa, I think that the next thing that's going to happen is that HCM will get a lot more attention in the press, in the scientific press, at meetings, because now there will be a great push to have HCM come out in the open. So it's still a disease that many people don't know about. They don't hear about it. So then the next good thing is that there will be more funds, more research triggered by this story.
Sorry, my phone's blowing up here. Yes, and it's already happening. We held our patient-focused drug development meeting with the FDA that was only made possible by funding from the pharma industry, because we all have a shared mission now. And when we all have a shared mission, there's more resources for us to work on to provide more support services to the patient population and more education. And you're going to see a lot of stuff rolling out in the next 6 months to a year from the HCMA that is due to our partnership with industry. Industry doesn't have to be the bad guy from the big pharma. It can actually be somebody who shares your mission, vision, and values, who wants to help improve the lives of patients with HCM. And that's what I'm finding with our partners. So I'm really happy about that. So lots of thank yous. We have family in Lebanon knows about it now. That's awesome. And just lots of thank yous here. There was one other question that
can you take the drug if you have AF?
Yeah,
yes. You can take the drug if you have AFib, but it will not affect AFib. So you will have to treat AFib as you did before. So you're not taking that for the AFib, but it's perfectly okay. So several of our patients had AFib when they enrolled. They were not allowed to enroll with AFib at that point in the moment of the baseline assessment, but several of them already had paroxysmal atrial fibrillation at the time of enrollment.
I'm just going to go through all the thank yous here to give them the press too. Everybody's saying thank you and these thank yous are to the whole community. You're the representative of all of the investigators, and as well as for our industry partners. So there is a question that I'm saving for last, because Gwen always asks these great questions. What, if anything, surprised you and your fellow researchers in this trial? Was there any oh my gosh moments?
Yes, there were several my gosh moments. There were several. I was blinded to the echoes, so I could not get into the room when the patients were getting the echoes as a PI, and I saw the faces of people coming out of the echo room, and they could not contain their like enthusiasm, having seen the patient at baseline. And the point is, it was so difficult to blind the study because the effects were so staggering. But there was one gosh moment when there was one patient, and then we saw this in more than one, that in whom the ECG is totally normalized, and that is something I have never seen in my life. So this lady had a profoundly abnormal ECG with T-wave inversion all across the board, and had this for years. And during treatment, the T-wave just went up, and the ECG normalized. So this is something I honestly have never seen. I'm looking into this now.
Inverted T wave to a normal T wave?
Mm-hmm. And that's happened more than once. So I'm actually going to look at this systematically, but that I think is extremely promising. And this, I can show you. I mean, I have the pictures in my cell phone, but that's really quite interesting because as you know, we have studied the electrical mechanisms of electrical derangement in human myocardium taken at surgery in Florence, and there are a number of electrical channels that go berserk in HCM. And the hope I'm saying the hope because we don't have data, but is that normalizing contraction may also help normalizing the channels on the membrane. That will mean lowering electric risk, lowering arrhythmic risk. That is my secret hope in the box. But of course, it's still a wild guess right now. It's not. I cannot say. But that was really definitely a gosh moment.
Yeah, I share everybody's enthusiasm. I'm like, damn, I missed all this stuff. My heart's gone already. So I'd recommend a trial on a new drug versus my pathway. So I will give you a moment here. You're sending shivers down the spines of some of our viewers with the possibilities of better treatment. So you and I were supposed to be together in March in Italy, and that didn't happen for reasons that I wonder why. But I want to take a moment and ask you what the plans are for your European Conference on Cardiomyopathies in Italy. Are you doing this?
So we have tentatively rescheduled for next April, but we have still so much like walking on edge here because we don't know. There's talks of new lockdowns, and so it's really a little early to spread the word around. I think we should probably, what really is the turning point is when schools start, because if we get through the first sort of weeks of schools without numbers going up like crazy, then we can probably start making plans.
Well, I'm hoping that they'll let us out of the country to come join you.
It will happen for sure. I just fear to say when.
Yeah, when I need to come back and walk that city with my good heart and share the message with the European community as to what we're doing. So I will let you go to sleep now because I know it's really late in Italy, and I thank you so much for spending the time with us today to share these exciting and thought-provoking and encouraging results. So on behalf of the entire patient community, we thank the entire research community for this really uplifting message.
Thank you, Lisa. Thank you, everyone.
All right. Thank you, guys. Tune in. For those of you who have not registered yet, the HCMA's Big Hearted Tour starts Thursday night. You can sign up here on the Facebook page, or you can sign up from forhcm.org. We will be starting our tour with San Diego and Scripps team. So we have 4 really great talks planned for you for Thursday night, and you can look at the calendar and schedule yourself for any or all of the Big Hearted Tour. You'll get different perspectives on HCM from around the country, and then we'll be adding some other features from around the world. Also coming up, starting on September 11th, Marty Marin from Tufts in Boston and I will be starting our monthly podcast where you'll be able to join us and ask questions. Stay tuned, more on that. And then on the alternate weeks, on Fridays at 11 a.m., you'll be able to join me and Dr. Harry Lever of the Cleveland Clinic for a similar formatted program. live Q&A that'll be available on Facebook and then be available on podcast, iTunes, Spotify, you name it. We're going to get out there and we're going to get information on HCM everywhere. You'll be able to listen to us while you're driving or watch us while you're viewing. So thank you all so much for joining us today, and we look forward to continuing this conversation with you all. Have a great day.